In this session, we're going to go over how to use the 1 Minute Preceptor effectively in a clinical setting. The 1 Minute Preceptor is a very brief strategy to make sure that we incorporate just a little bit of learning and teaching into a busy clinical setting. And it really only takes a minute. So the 5 quick steps is we want to ask our learner to get a commitment and to probe for supporting evidence for their diagnosis or plan. We're going to then teach a quick general rule and then tell them some feedback, either to reinforce what was done right or to correct mistakes. So we're going to work through a sample case. I just saw a 24-year-old woman with a sore red area on her left thigh. It's been there for about 10 days. No known preceding trauma. On exam, she's afebrile, vitals are normal. She has a 3-centimeter area of warmth and redness. It's raised, and I feel a little fluctuance in the center. Maybe try some cephalexin? So now that our student has presented this patient, our first step is to ask a question to get a commitment. As you notice from their presentation, they kind of left it open as to what diagnosis they're treating and were a little uncertain in their plan to give Keflex. So some example questions that could get a commitment are, what diagnosis does your exam support? Or, well, when would you consider an IND in this patient? Questions that you might ask in this scenario that are not geared to get a commitment are kind of more fact questions. What is the most common bacteria in skin abscesses? Or questions that clarify the history or exam, like, has she ever had skin infections before? Those may be important questions to ask, but they're not part of the 1 Minute Preceptor. So we're going to focus on these particular questions for today. So ask a question to get a commitment. So we choose to ask, well, what diagnosis does your exam support? And the student responds, I think this is a boil, and I believe MRSA is the most likely cause. Our next step is to ask for supporting evidence, if that's not already been stated by the learner. Sometimes the learner tells you their diagnosis and their plan and already has stated why. So if that's the case, you don't have to ask for the supporting evidence again. But in a case like this, where she says, well, I think this is a boil, let's ask to probe for supporting evidence. So in this case, we might ask, how do you differentiate a boil versus cellulitis? Now, there's some other questions you might ask here that are not probing for supportive evidence. So if you ask, well, what else could it be? Well, that might be a reasonable question, but that's broadening the differential diagnosis rather than asking the learner to justify the diagnosis that they just made. So when we ask, how do you differentiate a boil versus cellulitis? Our student responds, well, cellulitis would just be red or indurated skin, usually over a larger area, whereas a boil or a furuncle will look like this. It'll have a central area that looks full of pus with minimal surrounding spread. So once we've gotten a commitment, and once we've asked the learner for some supporting evidence, the next step in the 1 Minute Preceptor is to just teach one general rule. Now, in thinking about general rules, this is just a small pearl. We're not going to launch into a mini lecture about skin and soft tissue infections or about how to do an IND. We're really going to focus on one general rule. It can be about taking an effective history. It can be about physical exam. It can be about differential diagnosis. It can be about testing. It can be about treatment. Anything but one general rule, a pearl. And it's also helpful to try to match that general rule to something that's appropriate for that learner's knowledge or experience level. Now, learners can be very knowledgeable or very experienced kind of above their years, but in general, here's a progression in this case. So if you're working with a student, a general rule might be that, well, if furuncle is mature, then you can go ahead and drain it. But if the patient presents early, it may not be organized enough to drain yet. For maybe an intern or a resident, an appropriate general rule might be to say, well, in general, it's reasonable to defer antibiotics with abscesses less than 2 centimeters, no systemic signs and symptoms, not immunocompromised. Those folks usually do well with drainage alone. Whereas a more advanced learner, maybe you're going beyond this case and want to teach a general rule about treatment failure or about a more advanced topic. So saying, now if this patient has recurrent abscesses, particularly near their groin or axilla, that's when I start to think about hidradenitis suppurativa or a pilonidal cyst. So after we have gotten a commitment, probed for supporting evidence, and taught a general rule, now it's time to just give them some brief feedback. And we're going to reinforce the right and correct any mistakes. So in this case, we might say, you appropriately recognized this as a boil. To correct mistakes, we might point out, well, if you need systemic antibiotics, and we know that these are usually MRSA, Keflex won't work. You have to go to Bactrim or Clinda. So brief feedback to reinforce the right and correct mistakes. Other things to reinforce if they don't actually get the answer, diagnosis, or treatment plan correct. You can reinforce other domains by highlighting that their presentation was well organized and concise, or they did an appropriately focused physical exam. Like in our patient, I really didn't need to hear an exhaustive pulmonary or neurologic exam. It's great that you just focused on the relevant skin findings. This type of reinforcement can reinforce the valuable clinical skills that the learner is working on and helps them know what is expected. Other points to keep in mind when you're giving brief constructive feedback is try to avoid using negative labels such as bad or wrong. That may make the learner feel that this is more like criticism than constructive feedback. So it's useful to instead describe specifically what you saw or heard and how to correct it for the future. So let's look at an example of this. We're watching our learner do an ear exam on a patient, and they're holding the otoscope all weird and can't see the tympanic membrane, and the patient looks really uncomfortable. It might be tempting to just say, you were holding the otoscope wrong. Let me show you how to do it right. Now, there's probably not going to be a lot of hurt feelings about that, but you could imagine a scenario where you might need to approach that corrective feedback a little more judiciously. So frame it like, you know, the patient seemed uncomfortable during the ear exam. Let's go over how to position the otoscope. Let me show you how to hold it upside down when trying to see a canal that angles up. So you want to make it specific, and you want to make it future focused. Let's go over just a few more sample phrases and questions that can be useful as you're working through the steps of the 1 Minute Preceptor. Other questions to get a commitment. If you want to get them to commit about differential diagnosis, asking, well, what do you think is going on with this patient's AKI? If you want to get them to commit about what other information is necessary to make a diagnosis or make a plan, ask, what specific additional information do you need? Or if you want to get them to commit about modifying a plan, asking, well, what do you plan to do with the antibiotics today? Those all get a commitment. If we want to probe for more evidence, here are some sample questions that might achieve that. Asking, what were the major findings that led to your diagnosis? Or, well, you mentioned pneumonia on your differential. Why don't you think that's likely in this patient? Or say they want to scan this man's head. Ask them, well, what supports your plan to do the MRI of a patient with newly diagnosed lung cancer? When it comes to teaching a general rule, the key here is keeping them brief, pearls. For example, you're seeing a post-op patient with new or worsening hypertension. Ask about NSAID use because these meds can cause hypertension. There you have it. The 1 Minute Preceptor is these 5 steps. Asking a couple questions to get a commitment and probe for supporting evidence if the learner hasn't already provided that. You're going to teach them a general rule, one little pearl, and then you're going to tell them some brief feedback, reinforce the good, and correct something that they can do better next time.